endoscopic spine surgery at the lower spine when we have a surgical microscope. Because the surgical microscope is very common. It will be called now the golden standard. And everybody is trained on doing this. And the endoscope is quite different. I'm growing up in East Germany, so I learned a lot about philosophy and I learned about dialectic. That means when we're getting a huge amount of things, when we're getting a huge amount of this surgery, that means we get a big quantity. There will be the next step in kind of revolution to make a new quality. And though I think the endoscopic surgery is a new quality, and the question is the surgical discectomy, the laminectomy, the golden standard, must be endowed. If you look back in the history, especially of neuroendoscopy, endoscopes are very old. Cousini first used an optical system for visualization of internal organs in 1807. It looked like this. But even in 1879, Max Niese designs the first modern endoscope. And you see, these endoscopes look very similar to the scopes we are using today. And even there was a desire to achieve best visualization for medical treatment. Later, there was a vogue in neuroendoscopy. It started in 1910, especially in the time of 1920s. There had been a lot of use of intracranial endoscopes, and even William Mixter, who is the father of the discectomy, was one of the pioneers in neuroendoscopy. In 1924, he used the endoscope for intracranial surgeries. But at this time, the endoscopes, and especially the instruments, hasn't been well developed, so they went on a couple of problems and it stopped. Now we have a rediscovery of neuroendoscopy, and you see here, now we can do a lot of surgery, especially in the cranial region, as skull glass endoscopy. Now we have developments in vascular cranial surgery, though the endoscope in neurosurgery is really coming back. On the other hand, there had been an early development in spinal endoscopy. It started in 1931. It was more like an epiduroscopy, but people like Hausmann Forst as well as Schreiber and Hughes had been the first using endoscopes. I'm happy I was 91 together with Hans-Jörg Loy. So I did my first endoscopic procedure at this time with him together. At this time we didn't have any working channel scopes. We worked with knee arthroscopes, used the bipolar approach, and started to do our first things. Barbex Camping created the first working channel endoscope and developed the anatomic basics for endoscopic disc surgery. You see here, that's Barbex Camping doing his surgery. This was his first scope, and this was the first set we got in the market to doing a working channel-based endoscopic disc surgery. Why did we need it? We heard about this. We got new devices, we got new techniques, and though it's becoming more and more real to do endoscopic surgery, the big question is, give the microscope enough benefit? You know, we can have a 3D picture by microscope, but it's not necessary, because when you use an instrument, you get your third dimension. So even by a two-plane optical system, you can work in third dimension. On the other hand, you have good lighting. I think an endoscope is giving you better lighting. But you have a stabilized operation area. I told you I went in problems to using magnifying glasses, but I'm always moving my head, and so it was difficult. Yeah? And microscope is really stabilized. An endoscope is moving too. And though it happens when you start it, and you don't fix it in the beginning, you have problems to get your orientation. That's the reason the best is when you do this, to fix your optic on the disc and to work really proper. Because when you move it too much, you will lose orientation. This is the other slide about the history about this surgery. You know, Mixter published 34 his paper about discectomies. This led to an extension of discectomies, so he was called the father of the discectomies. But in 1952, this had been the latest paper of William Mixter. He went it out. He described all the pitfalls he went in, And he said the dorsal inner-laminar approach, its technique for discectomy, cannot be the final solution for treatment of the herniation. In this paper, he said it will take 10 years to solve all these problems. We are now more than 50 years later, and we haven't solved all problems on the spine yet. But this led to a lot of new developments, especially in the posterolateral approach. Smith started in '64, and a new placement of different steps in this surgery because there is a gap between failed conservative treatment and open surgery. And if a patient fails conservative care and this or her condition does not warrant a discectomy, arminectomy, or fusion, the patient is normally left without effective treatment options. And we know open surgery has problems. Look here, we have the studies from Sweden that register every patient will be under control, and there's a reoperation rate of 5% after 1 year and 10% after 10 years. Similar situation in Finland. They control every surgery, and at all there's a reoperation rate of 14%. So the first surgery, laminectomy, didn't solve everything. And at the end, if you look to the States, there we have the main lumbar spine study, that's peer research, randomized controlled by the health insurance. They figured out that at all 90.2 of the patients they underwent the first discectomy need a second one, and only 63% of the surgical patients were really subjectively satisfied. So the golden standard of microscopic discectomy cannot solve all problems. The advances, I explained it, minimal surgery. What means approach trauma? You see here, that's a picture of a microsurgical decompression. You see the huge damage you made in the muscles, especially you disrupted all the multifidi, the most important muscle of the spinal segment, and this leads to other problems besides the sciatica and the irritation of the nerve root. So I told you, I prefer to say minimal aggressive, don't harm the structures on the way to the pathology. The requirements I have shown in the anatomic lecture. Yeah? So we go back to microsurgery. Is it the golden standard? It's really most common for neurosurgeons. We have standardized and educated techniques. I think it's part of the residency of your curriculum. You will be trained 6-7 years in doing this kind of surgery. Yeah? You have a 3D visualization, and never forget, in most neurosurgical ORs, a microscope is available. You don't need any new instruments. But it's only the approach. If you use an open approach, for example here on the cervical spine, this gives you a better overview, it's easy to bring implants in, you can do a radical complete discectomy, but at the end there will be more destruction of tissue. If you do a minimal invasive approach for the endoscopic, for example, yeah? The endoscopic approach requires the knowledge of the anatomy to go directly to the pathological region of the disc that's damaged. Now we can do fusions on the cervical lumbar spine as well. We do only a selective removal of disc material. And never forget, the patients are more and more demanding and requiring these kinds of surgery. So the big question, we all have to be big surgeons and do big cuts. I think the way of view can solve the problems, and the lightening, the look there, it's the biggest issue. There's no darkness, there's sometimes only an absence of light. Yeah? So you have to get a good view to solve this. This is important to see how you do enlighten things, and you not only do a straight enlightening, you can do with an endoscope wide enlightening. And when you look here, the endoscope gives you a view behind the edge, because we have angulated endoscopes. You see it here. You have this angulation of this curve, but even when you do it like it, you do it in arthroscopy, you can turn your endoscope, you can widen your visualization field, and you can get all a bigger field. And so you have a huge overview with the endoscope even behind the edges, and you can see this here. That's happy pictures for the endless modulation. You see here what I'm doing. I'm doing like, it doesn't look sorry like this, but I look with the endoscope behind the edge at the whole inner annulus. You see here, that's the same movement. This is a technique for endless modulation we are using for districts too. And so you can see how you can endoscopic techniques are requiring an integral transfer of the single pictures like a mosaic to a whole picture. That means you have a lot of small pictures at the end. It's giving you a whole picture. I don't know what we do, doesn't matter. Maybe I have to show it to you later to you. Yeah? Then we got development of technical devices. It's like the TV sets. We started in the 30s with SIS TV sets from Ardennes, but today we are talking about HD TV. The same happens in the OR, and though we have the newest ORs, this is the technique by Storz, you have really high technology ORs, you have this OR1 system, that means you have high definition cameras, you have special screen, you have special technology, especially the AIDA system. Yeah? You can use new xenon light sources. The next step will be LED you're getting for this. You have this documentation system, AIDA. It's really very recommended. It's one of the best in the market at the moment. You have these special pumps you can use, and you have special design apparatus for bursts like this. It's a motor system for the high-speed bursts. The approaches I have explained to you, that you go from lateral to this, you can approach 60% of the disc, you have no bleeding unless after a scar. I don't know why the video doesn't work. Okay. This is the beginning, how we work in 91. This is a bipolar approach. That means we use first on one side the endoscope, from the other side we use the instruments. Then we improved it by using working channel scopes. On the other hand, we simplified the whole technique with physical techniques. I will explain it later. It's a very simple technique for beginners, for an inside-out technique, using especially the steerable radio frequency. And you can get pictures as well by this small, tiny endoscope to control what you have done. And we are using more and more the extra distal techniques for the working channel scopes, as I did explain it here. Here the safe zone again, where you have to go. I showed you. Sometimes you have problems with the crest, so you have removed bone to go in. You are using these different instruments, and here you can see how we are doing it. You see we are using this special kerosene to remove the lateral facet parts of the SCP to go into the spinal channel. Very important is to stop every bleeding, to avoid any red out by the endoscope, because otherwise you lose the view. Here we are using the special diamond high-speed burr to remove the bone, and we are really opening this foramen to go inside. And when we have done a proper preparation of the disc material, it's very easy to remove this huge sequester or this restricted material, and to go inside, because when the sequester is inside of the spinal channel, you cannot go to the neural structures because the neural structures are pushed away. But when you have removed like this huge piece, you see now you have the full deliberated nerve root, you can check it, and you have full decompressed neural structure. And this is what we want to do, and you have only done a small damage by your approach. The other technique is, I told you, I go as far lateral as possible to use a far lateral approach for this. Especially we are using it when you have medially located sequestrated material. If the material is behind the transversing nerve root, and you have seen this picture too, you see that the situation. Here you see the nerve root. The sequester is behind the nerve root. That means by the instruments you have to elevate the neural structures, go under the nerve. That's sometimes a little tricky to catch this huge piece is lying here. We don't pull the disc, we don't destroy the disc, we don't make a hole in the disc, but we can catch at the end this huge piece, and you see how you can remove it. Dr. Gunn visited me, he saw at the end we called, or Dr. Weaver, we called it outside technique, to work only in the spinal channel without opening of any disc. The interlaminar approach is getting more and more popular. The reason is a lot of spine surgeons are very common with the view, with the technique. That means we are going straight spinal channel. You see here the view, you see the nerve root, you see the dura, and you see here the nucleotomy we have done. You can do a bony decompression of the recesses, like to decompress for spinal stenosis. And here you see some picture of this. You place a panel like this. You go really straight through the interlungar window in the epidural space, and you can make a decompression. I have shown you this, how less aggressive it is in relation to the epidural membrane. Yeah. Though at the end I want to show another issue I love to do with the endoscope of facet twist. You're seeing it very often. Yeah. You have really minimalization of the approach trauma by the endoscopic sheath. I use the meter sheath for this. You will preserve all the dorsal muscular ligamentous attachment. Stability, very important. There's a big discussion about the treatment of these cysts. Do we need infusion or not infusion? I think fusion is the last step. You do less bony construction. You have no intraoperative blood loss, and you have a really fast surgery. You see here a nice case I have done. This is this huge cyst there, L5S1, and we use the endoscope like this to remove this cyst. You can see here how we are doing it. We are using this keratin to open and remove a little bit of the phlebum, to do a phlebum decompression. Here you see the facet cyst, you see the neurostructures. You have to do really a proper, careful preparation because there are always a lot of adhesion between this cyst and these neurostructures. You see here it's a ganglion cyst, it's coming out. When you have done this, you can turn the sheath. The cyst is going inside of the sheath. Then you use different instruments to remove this cyst. You see here that we partially remove the cyst. You see the quality of the cyst, but at the end we are removing the whole material. Now we can check the whole epidural space. Its neurostructures are absolutely free. And here you see the picture before and after this surgery, and you see we totally remove this ganglion facet cyst. What are the outcomes? I have shown on Saturday this special lecture about the evidence, but we know we have an evidence for this surgery. We know that the endoscopic procedures are equal to open surgeries. Sometimes we are showing we have less complications. There is an evidence that we have economic benefits, especially in relation to the return to work. Though the endoscopic surgery has a place. Here another review that the current data suggests that microsurgical and endoscopic techniques are superior to the classic technique for the treatment of single level lumbar disc herniation with respect to the volume of blood loss, systemic repercussion, and duration of hospital stays. And all three surgical techniques were found to be effective for the treatment of single level lumbar disc herniation patients without degenerative vertebral deformities. That's a review of all randomized clinical trials. The funny thing is, especially in the UK, everybody's referring to Cochrane. First, I did any research about Cochrane. Nobody knows who founded Cochrane. Everybody in Cochrane is scared to lose money. I approached Gibson directly. Then they did really selected research. You know, the first Cochrane release was 2005. After we attacked Gibson, we had to do another release in 2007. You can read it especially in relation to the laser. It will be funny, then there are 3 more randomized controlled studies. He left out 2005. And since 2007, there was no more review anymore. So I think Cochrane was a good idea, but Cochrane followed special interests. So even evidence-based medicine have a strong bias. So we can assume the advantages of the endoscopy is really minimal aggressive approach with less complications. Reduce pain post-operatively, that's sometimes scary. I thought you have to calm down the patient. The patient doesn't take the surgery serious. You have a short rehabilitation, a fast return to work. You can do it without general anesthesia, and you have like a neuromandatory cause of the local anesthesia. You have a direct approach to the pathology, and you have less or no bleeding. But never forget, it's really a technical, ambitious procedure. It takes time to learn. After the beginning, you need some time to high radiation, we have long-lasting operations. There are some nice papers about the shallow learning curve in relation to the radiation you are using. When you are not sure, you do more radiation. When you are very common with this procedure, you can reduce your flow. That means you have a steep learning curve, and there's a need for special instruments and equipment. You have to purchase it efficiently. What will be the future or the new development? I'll talk about the high-speed bursts. We have different kinds of new high-speed bursts, so we can do really good bony decompression, especially by the diamond bursts. On the other hand, we are looking how we can solve problems. You see here, I did by this post-leukotomie syndrome with a lot of scar, this damage of the dura. This was a dura leak. And you see how you can seal this damage of the dura through the endoscope with special frequent-use patches, so you can close this whole leakage to avoid any problem by this dura damage. Then we discussed about complications. Can get scar tissue. Here you see a picture of the scarring of the foramen, especially after bony decompression. It happens, but it happens very, very rare. Then very important is the big question about implants. We have a further improvement of the instruments to do this. We can do at the moment bone infusion in the vertebra. We have special designed implants to do a full percutaneous 360-degree infusion. And we are working on biologic nucleus replacements. Here you see the former way we had it done. We started with the B-twin, then we did this percutaneous screw placement by the small incisions, and we placed this bone down inside. But the latest step is this new device. There's an expandable cage. You can see we place it through the endoscope, then we expand it, we get a distraction, and you see how well this endoscopic assisted cage is really placed in the vertebral space. Here we are using facet screws to simplify. We can do this whole fusion with 2 1-centimeter incisions. Though we can conclude, the endoscopic techniques are an alternative to the microscopic surgery. It's not a full replacement. You need still open surgery. And never make the failure we learned in general surgery. Today, a doctor is able to do laparoscopic gallbladder removal. But a lot of doctors are no more able to do it in open surgery. Though beside the endoscopic techniques, you must be skilled in the open techniques. The same situation we have on the cervical spine. Cervical endoscopy is dangerous. You must be able to open a cervical neck. Because when you have a carotid injury, you have to stop bleeding. Otherwise, you will go in a lot of trouble. And I know cases in the world, there have been all 6 cases of death after cervical endoscopy. This had been surgeons, they are not being able to control the bleeding caused by the endoscope. Because they never had learned to use a knife on the neck. Then, the endoscopy of the spine requires, besides the skill, the exact knowledge of the microanatomy. You have to know what you're doing. The microbiome of the anatomical structures in the field, operation field, is the knowledge of what helps you to avoid complications and give you a good outcome. And you have to know about the procedures, and you have to be well teached in it. So thank you for attention for this lecture. Are there any questions to this topic?
How many patients do I have after as they have
This is I have less. When I started, I went for a while to general anesthesia because it fastened my work into it. During this time, I went up to nearly 30% anesthesia. Now I went back to local anesthesia to do any anesthesia on the nerve. And by this, but now I know that where I have to be careful. And the most important thing is to really be careful near the nerve root and near the ganglion. And so for the anesthesia, for me the most complicated places are extracorneal deviations. Because when you work on these extracorneal deviations, sometimes you have to work under the ganglion because they are located under the ganglion. And then you have to push with a tiny instrument the ganglion. And these patients are responsible. But by using this technique, by really opening foramen, you can avoid this. Another problem is the endoscope with the foramen. Then you squeeze the ganglion and you will get but when you use this other technique, and I'm working mostly outside of the foramen with the endoscope, I put all my instruments in the spinal channel, yeah? You can avoid this.
So in your hand you never hammer.
Oh, I take all this on my multi surgeon. I love the hammer, yeah. But I never push or force the endoscope with the foramen. What I do before I go with the endoscope with the foramen, I release the foramen. I widen the foramen. So I can place it very sensitive.
Can you give the name of the string that you...
No, there are no different ways. There are some drills by Storz. I use a lot this kerosene or the high sticker. Storz has reamers for this, yeah. And okay, we are using these kerosenes to remove bone before. But you have to do, one of the problems is, especially by limb surgeons, limitations. That means you have to really explode and proper work. You have to do really cleaning up of the foramen. You have to see where you are, you have to see your structures, then you can do it. Sometimes I see some doctors are impatient, they don't see nothing, they see only there must be foramen. Then they look at the fluoroscope, take the mollet, and push everything in. This will be the problem. When you do open surgery, you want to see what you're doing. Same as here. And you have to use your orientation. The inferior clavicle is the safest place. You have to go always from the inferior clavicle. When you lose orientation, you go back and start again. Never do any wild switching.
During the operation you use your hand, you can no hold the...
I use my hand. I make it free-handed.
So
but it's sometimes difficult because that's what I told you. If you have your scope fixed on the disc in the beginning, it makes it much more easy. Or on the other hand, I explained to you when I train the doctors, yeah, what's the normal way? They are starting. They are fixing the cannula on the disc. Because they're pushing it into the disc. So there's not a lot of movement, but they have not such nice pictures as I have shown you. They see only disc in the tape, but they are successful. Then they are watching what we are doing. Oh, I want to have the same picture. I want to see the nerve root, I want to see the ganglion. Then they start to stick with the scope in the frame. Then they are getting some patients with really severe neuropathy. And then they say, endoscopy never works. That's a normal way. I see it so very often by me. On the other hand, when you're visiting doctors, they are asking, oh, doctor, can you show me the nerve? The best is, I don't want to see the nerve. Because when I don't see the nerve, I'm awake, I'm protected. That's quite different, because when you start to liberate the nerve, to take the fat off of the ganglion, you produce. But you have to know what you are doing. So the rate of dysesthesias is related to your experience. And one of the messages today is you cannot learn endoscopy in 1 week. But this is what a lot of doctors are thinking. For me, it took more than 10 years to learn it. Okay, the other issue besides the lumbar spine is the cervical spine. I told you, cervical spine is a little bit more tricky. We can use endoscopes here. I developed a special system for this. I worked a lot on this endoscopic techniques on the cervical spine. But the first message is you have to be careful. There are not so much doctors using cervical endoscopes, so we have an overview. I told you we find out there have been all 6 cases of death. All these endoscopes haven't been in the proper hand. If you do cervical endoscopy, you must be able to do open surgery on the cervical spine. You must be able to control any problems. On demand, nowadays, a backup of a vascular surgeon. I got by myself a case of a carotid injury. It's very aggressive. Okay, I solved it after 25 minutes. careful when you do this. On the other hand, it's a less traumatic procedure too. I call it from non-endoscopic laser disc conversion to cervical percutaneous endoscopic cervical discectomy. The reason is I do a lot of percutaneous laser discectomies on cervical spine too. They are very effective. I did one controlled, not randomized, but a controlled study between this laser discectomy and endoscopic discectomy. This worked. Well, the patient accepted it. It was ethical possible. So you can see what is the outcome. But going back, when we look at the history of cervical disc surgery, it started really late. Building in Scottsville did the first posterior approach in 1950. Then we got Klauer, Bailey, Smith making the anterior approach. It took nearly 10 years and it came to Europe. And with the microsurgery, the use of the microscope of the cervical spine, we got another big advantage. But on the other hand, we got all these percutaneous procedures for the cervical spine. They are working. It's limited, the effects, but the same as on the lumbar spine, the proper patient selection is very helpful. Look at the history of it. It started very early. At the end, the first cervical procedure had been done by Gaston. Somebody learned it in France by Gaston. Though somebody did a lot of development of this technique. On the other hand, Fontanella in Italy did another technique. For example, he did dorsal endoscopic discectomy. The introduction of the laser had been done by different guys like Lee or laser assisted Chu. Then we got another technique by Hoagland from the Alpha Clinic. He did an endoscopic assisted chemonucleolysis. That means he injected chemopapain, and after 20 minutes he removed all the material with the chemopapain. The advantage was he stopped the effect of the chemopapain, though he got a limited chemonucleolysis. Well, we need this surgery because we got good experience with the endoscopic and non-endoscopic techniques on the lumbar spine. We got the right use of minimal invasive non-endoscopic procedures on the cervical spine. I talked about the laser decompression. And we got the aim of an integration of different procedures and experience with the minimalization of the operation trauma as a further development of the existing operation methods and principles. Are the disadvantages of the open spine surgery? There are. If you do a standalone discectomy radical with non-fusion, you can produce collapses and instability much more than you have by the insert technique. You can be confronted with injuries of the recurrent nerve, esophagus, trachea, laryngeal nerve. There are description up to 10% of this laryngeal nerve injuries as retractor injuries. Sometimes you will see when you do fusions, you can get pseudarthrosis, dislocation of implants or kyphotic deformities. And never forget, adjacent disc level diseases are very common on the cervical spine. What is the difference between a microscope and an endoscope? You need a new mind for the optical view. Look, this is a microscopic view of an umbilical joint. You have a huge overview, but at the end, with the endoscope, you see only this small edge. That means you see only this small piece. So you must be much more aware what you are going to see with an endoscope. The other question is always use gas or water. Normally we are using irrigation for these surgeries. Here you see the use of irrigation. We have this aquarium-like effect. I changed my cervical endoscopy to the application of gas. And what are you going to see? You have nearly a view similar to open microscopic surgeries, so you are much more common with this view. On the other hand, we got this discussion formally in the arthroscopy. What is better, gas or water? So we recommend champagne. We get both in it, but nobody can pay for it in medicine. What are the indications for this? You have huge sequesters, you have adjacent diseases. A lot of patients coming after a fusion, they don't like a second fusion, I want to get another procedure. So these patients are approaching you. We use as indications neck pain with rotation down the arm, symptoms of tingling, numbness, as well as signs of sensory loss, muscle weakness, or decreased reflexes in the upper extremities related with the level of involvement by the MRI. can be used by severe cervical headache with neck pain by positive MRI, by cervical syndromes. Myelopathy in case of soft discal affection. Yeah. We demand a time of 8 weeks of conservative treatment before we do a surgery. Yeah. You can include junctional disc herniation syndromes in post-surgical fusion, as you have seen in this picture. And you can do multi-level discectomies in one sitting. Contraindications for this procedure: severe cervical spinal stenosis, pre-migrated disc fragments not located at the disc level because you cannot work behind the head, advanced spondylosis. Now, I include previous strumectomy. We call this case with carotid injury. It was a wife of a colleague. He pushed me to do this. Normally I have to use it. This female got a strumectomy, and when I opened the neck, I thought I never had any chance because there had been such a lot of adhesions inside after strumectomy, so I never was able to push the carotid artery away. On the other hand, it's very important to check the carotid arteries. This one case of death by my friend got a second reason for the death. It was not only the bleeding, she got stenosis on the side. So by stopping bleeding here, blood supply from the other side. So I do always a check-up of the carotid, of the vascular supply before I do such kind of surgery to exclude these patients with the contralateral stenosis. Then severe instability. I think here you have to do fusion. You can do endoscopic fusions. Other pathological conditions. And in Asia, more present ossifications of the posterior ligament. What is the goal of this special technique? It's a selective decompression and extreme closure of neural and muscular structures in the ventroabdominal space of the cervical spine after removal of the disc fragment by minimal traumatization to reduce mobility of the approach by extensive preservation of the biomechanical capacity of the rest of the disc. You mean a degenerated disc has not the biomechanics like a healthy disc, but there's rest. And when you leave it, you have it compared to a bony fusion. How we are doing this? We will see the endoscopic view of the anterior ligament. Then we create a channel through the disc, and then we can, through the posterior ligament, remove this disc material. Now, this is working here. Now you see this animation of the principle. You see we are going through the disc with the sheets. That's a special expansion disc here. And then you can remove and decompress it like you see here. You can see the better on the bigger picture. And though you do only a selective decompression in the disc by using this working sleeve. Here you see it in the lateral view, especially the expansion sheets. You go with the sleeves inside. By turning, you destruct the intervertebral space like a flower distractor. Then you have enough space to work posteriorly. And then you can go straight with the pathology and remove the disc material. How the technique is doing? I prefer to do it in general anesthesia. It's possible to do it local as well. But my personal experience was when you go with any complication, then you have to do an additional intubation. It's better to have the patient really sleepy. It makes it much more easy. So I do all my cervical cases with the endoscope in general anesthesia. The non-endoscopic cases I do still in local anesthesia. You place the patient in supine position with the neck extended. You need further control to see what you are doing. Very important is innervation with displacement of the carotid artery laterally, medially, later. Then you have to do a steered placement of the needle, considering the MRI scan under fluoroscopy into the disc. And then you use a special expansion sheet to go into the intervertebral space. Here you see the planning, you see this extrusion, you have to plan whether you go left or right side, so you have to design the direction of your working channel. Here again, this special placement of the needle by pushing the structures with the finger away. Here we have a nice picture by Gaston Witt. In the CT scan, you see how you can go with your finger directly on the spine. You can feel heals the spine, and you see how you push all the structures, carotid and medial structures away. These are the special new expansion sheaths. This is a very special technique. You see here, it's not right, that has been done by the company, not by the doctors. Normally I go in the midline inside, but you see, you place your dilator, then you push this sheath in the disc, and here, when you place it and you turn it, you distract ground and end plate until you get a widening of the posterior part of the vertebral space. Here you see the different instruments we are using. We are using the special burrs, we are using this kerosene, we have hooks, and most common to use the transfer to remove free disc posterior. On the other hand, we started to do research about the radio frequency in the cervical disc. It's a little bit different than you are using in the lumbar disc. You see here that's the cervical disc. You go straight to the spinal channel, so you have quite different effects. You must work with this radio frequency very careful, but you can use it. You see here, that's the trigger flex on the posterior ligament. And when you look here, you have a view. You see here the posterior ligament. Here you see this trigger flex. It's much more narrow in the cervical disc than in the lumbar spine, but you see the slight bleeding on the hole in the posterior ligament, and we can do a proper calculation of this bleeding on these places. You need less energy than you do with lumbar, but you can stop and decompress with the radio frequencies too. On the other hand, this nice picture again, you see we decompress this, you see now the bone, you see the nerve root here, and we created the channel, and this was a huge sequester, and you see here still any free material, and you see how you can pull out this material with tiny transfers to get a proper decompression of the spinal channel. I don't do anymore any discogram cervically. The reason is I saw two cases when I pushed by the discogram huge sequesters in the spinal channel by the increase of pressure cervically, so I avoid now to do any discogram cervically. Here you see again a video of this. You see how we decompress the posterior part. You see the posterior ligament. Now it's a big question: is there something behind the edge? We are using for this a special hook. You see the posterior ligament. You see the bony edge, and now you can check whether something is behind the edge, and you can mobilize it and remove it. But at the end, there's really a nice decompression in the cervical space. Now back to the study I told you. We included in this study 30 patients. 14 underwent laser discectomy, non-endoscopically. 16 underwent endoscopic surgery. We did different levels. We got a preoperative pain between 7 and 10. And we had 2 reoperations after PLTN, 2. One I did with the laser, the other one with the endoscope. And after the endoscopic procedure, we had to do 2 open surgeries caused by inadequate compression or instability. When you look at the outcome, you see it's nearly similar. That's okay, but you see especially the endoscopic technique is a little bit better. But on the other hand, we got in the preoperative group, because it's difficult in a controlled study possible to cross over more severe cases. If you use a McNabb, you see here too that we got at all in the endoscopic group good and excellent outcome of 76%. This is not bad for this kind of surgery. Neurological